Good evening, ladies and gentlemen. My name is Louis Perrault from Montreal. My co-chair is Zan Hu. We welcome to this session, Optimizing the Saphenous Vein Bypass Graft session. We have 5 great speakers and a panel discussion at the end. We'll start without further ado from Toronto, Dr. Stephen Freems on how outcomes with the saphenous vein grafts improve over the past 20 years. Stephen.
Thanks, Louis. Thanks, everyone, for the invitation. I'm very honored to be here and to present on saphenous veins. So these are my disclosures. This is an outline of today's talk. So the best estimate of the SVG occlusion at 1 year was established from this individual patient meta-analysis from 48 studies, including over 40,000 vein grafts. At 1 year, SVG occlusion was determined to be 11%. There is a recently published manuscript reporting on a systematic review by experts from ATS, EACTS, and STS, and published simultaneously in JTCVS, EGCTS, and Annals. In the manuscript, there are key messages or best practices about bypass conduits rather than recommendations per se. This is a section on no-touch SVG harvesting. There is consistent data showing better patency compared to conventional SVGs, but no evidence that to date the clinical outcomes are improved. There is an increased risk of harvest site infections. There's also a section on endoscopic vein harvesting. Clear evidence that leg wound complications, including infections, are reduced. A number of studies suggest that graft patency may be reduced, although a single large RCD did not show any evidence that MACE was increased with EVH. The 2018 European guidelines are the last set of guidelines that the surgical societies endorsed. Endoscopic vein harvesting received a 2A recommendation to reduce harvest site complications. No-touch SVG harvesting received a 2A recommendation when open harvesting is used. What is a no-touch SVG? Well, briefly, the no-touch SVG is pedicled, harvested atraumatically without manual dilatation, and checked for leaks when subjected to aortic pressure. The Swedish surgeons who pioneered the no-touch technique initiated a small single-center longitudinal angiographic RCT comparing the no-touch and conventional SVG. But 8.5 years, graft patency was substantially and statistically higher in the no-touch veins. The patients were then followed up to 16 years postoperatively. The patency of the no-touch SVGs continued to exceed that of the conventionally harvested SVGs. Also, the patency of the no-touch SVGs were similar to the patency of the LITA grafts, or at least non-inferior, of the same patients. This is the largest study, including more than 2,600 patients from 7 hospitals in China. We'll hear more about it later in the session. We measured graft occlusion at 3 and 12 months postoperatively by CT angiography. Graft occlusion in the control veins was very low at 5% at 3 months and 6.5% at 12 months after surgery. Still, graft occlusion was substantially reduced with the no-touch technique. Wound infection was low overall, but higher in the no-touch veins. The other large RCT is entitled Swede graft, a 900-patient Nordic RCT with a primary composite endpoint of graft failure, repeat revascularization, or death at 2 years. Recruitment is completed and should report in 23 or 24, well, 2024. This is the vest, a cobalt chromium mesh stent to externally support the saphenous vein. It is approved in Europe. The external support is intended to reduce wall tension of the saphenous vein as it adapts to the arterial circulatory pressure. This should result in less intimal hyperplasia and reduced late graft failure. And external support of vein grafts is very successful in animal studies. Here you see 2 SVGs with the vest. These are the different European vest clinical trials. The VEST pivotal study was presented at the 2021 AHA meeting and published in JAMA Cardiology. There were 224 patients, and each patient had a supported and an unsupported graft using within-patient randomization. Graft occlusion or diffuse graft disease occurred in more than 40% of patients. There was no difference in graft occlusion between the stented and the control SVGs. In the primary analysis, intimal hyperplasia was non-significantly reduced in the VEST SVGs. An exploratory analysis restricted to patients with 2 patent grafts, intimal thickening was slightly but significantly less in the VEST SVGs. In an earlier meta-analysis comparing endoscopic and open vein harvesting of 44 studies and over 250,000 patients, wound infection and other wound complications were substantially reduced with endoscopic harvesting. However, vein graft occlusion was greater, largely driven by PREVENT-4 and RUBY. The EVH findings in PREVENT-4 and RUBY are observational results in randomized trial. Surgeons decide which technique to use for SVG harvesting. It is unclear how many veins need to be harvested before being competent. This is a concern for training programs. This prospective study considered experienced operators to have greater than 900 cases and inexperienced to have less than 100 cases. The veins were subjected to OCT before grafting, and the images were viewed by 2 blinded reviewers. There were more injuries in veins harvested by less experienced operators. There was no difference in graft occlusion. However, higher injury scores were associated with higher occlusion rates. This is the regroup trial. It's a VH study comparing MACE in patients randomized to open or endo SVG harvesting. They were all experienced operators, and that was defined as more than 100 cases. Wound infection was reduced as expected with endo harvesting, but was low in both groups. There was no difference in MACE, nor in the components of MACE in the study. In more extended follow-up, there continued to be no difference in MACE, suggesting there's no large difference in the quality of the harvested veins between groups. I'll now talk about SVG storage. Another secondary study, the PREVENT-4 RCT, showed that graft stored in a buffered solution rather than saline or blood was associated with improved patency. This again is an observational result within a randomized trial. In this laboratory study of human SVGs stored in a balanced salt solution, at 1 hour they still had cell viability. This is seen with green fluorescence. It was lost at 6 hours, seen with red fluorescence. However, specimens stored in GALA, a balanced salt solution, with glutathione, ascorbic acid, and L-arginine were viable even after 24 hours of storage. The test solution was evaluated in a multi-center trial of 125 patients with serial CTs at 1, 3, and 12 months. The trial utilized a within-patient randomization. The primary outcome was not different between groups, while other secondary graft imaging endpoints favored the test solution. It's also very important to remember that medical therapy is crucial in terms of SVG outcomes. In this network meta-analysis published in the BMJ, the addition of clopidogrel or ticagrelor to aspirin was associated with reduced graft occlusion. The Canadian Cardiovascular Society has recently published new guidelines related to antiplatelet therapy, which presented last month at our annual meeting. DAPT received a weak recommendation for post-CABG patients with or without recent ACS. Ticagrelor or prasugrel-based DAPT was preferred rather than clopidogrel in ACS patients. The preference for ticagrelor or prasugrel was based on ACS patients due to the pronounced mortality benefits seen in CABG subgroups compared to clopidogrel-based DAPT in the Plato and Triton RCTs. And this is the treatment algorithm. There's differences for on versus off pump, and for ACS, yes or no. There are 2 ongoing trials. The top CABG trial, comparing 12-month DAPT with 3-month DAPT, and the Odin trial, comparing 1-month DAPT with aspirin monotherapy. Also, high-intensity Statin therapy is very important, and this is recommended in patients less than 75 and moderate intensity for patients more than 75 years of age. We strongly believe the benefits of CABG are dependent on patent functional grafts. However, asymptomatic graft occlusion is common. This individual patient meta-analysis looked at this, and these are the graft occlusion results in these patients. They are associated with cardiac events, most commonly repeat revascularization, but also mortality. I'll skip this slide because I'm running late. So these are the conclusions. No-touch vein harvesting is associated with improved patency, but there are increased wound complications. Endoscopic harvesting is unassociated with wound complications. The results of externally supported grafts are unclear. Longer-term results are pending. Balanced salt solutions may be worthwhile. Medical therapy is really important, and improvement in SVG patency remains very important for the patient. Thank you.
Yes, we'll try to do just a few questions because at the end we'll see if we still have the focus. Any questions from the audience? If not, I have a few. So you're well known to be identified with the radial artery space, and so I don't know how you got caught up with that lecture. Anyways, but so have the results improved in the last 20 years? Yes or no?
The answer is yes.
Okay. And would you use a vest on one of your patients with the data you have right now, if it was free?
I don't think it's an approved device in Canada.
But
I would not, but I think it may have a role if you had to use a vein graft that was of poor quality.
Okay. And we don't want that, but if you had to have bypass, would you have an endoscopic vein harvesting?
I'm fairly thin, so I think I could safely undergo open vein harvesting and have a reasonable wound complication rate afterwards.
And obviously an experienced operator.
Well, I think I could undergo open vein harvesting,
Yeah,
but no matter what. But I think it's probably more important for endo than open.
All right, thank you very much. You can have a seat.
Good question.
Thank you very much, Dr. Freems, for your invaluable insights on the use of saphenous vein grafts. And our next speaker is Dr. Alistair Royce, who is the acting head of surgery from Royal Melbourne Hospital and the University of Melbourne, Australia. Today he will talk about elimination of saphenous vein grafts.
Thank you, and thanks to the organisers for inviting me. I did question my place in this particular session. These are my disclosures. Now, this slide summarises the basic problem of vein grafts. On the left panel, you can see a vein graft 9 years post-op, which, comparatively speaking, looks pretty good. And yet only 2 years later on the right panel, there's been tremendous progression of disease. Now, this coronary territory is dependent on flow via the graft, and when that graft fails, you are going to have acute coronary ischemia, from which the patient may or may not die. There's a second thing that's very rarely spoken about with venous versus arterial conduits. Let's just say that you are the average 67-year-old patient of yours, 67, 10 years post-op. The vein is now exposed to the arterial circulation for 10 years. But the arteries we've used have been exposed to the arterial circulation for 77 years. And here you see several examples of radial or mammary many years down the track. It doesn't make logical sense that after all these years post-op, as well as the patient's life, they will suddenly develop disease and keel over, right?
Maybe half.
This is an angiogram series from Royal Melbourne, where one angiogram per patient was displayed. Along the x-axis, you see the period post-operatively. Really what it shows in green and red, the two arterial grafts have their patency set very early and thereafter appear essentially never to change, no matter how far down the track you look. But for the vein, that's not the case. As we all expect, progressively declines in the longer term. In respect of mortality analysis, the mortality, the death that you're measuring, will result as a consequence, all things being equal from the cardiac perspective, from graft failure, which caused ischemia in the coronary territory supplied by that graft, and then causes death in some patients. But you're not having that happen when you have ongoing patency. So mortality analyses, in a sense, are an indirect measure of the grafts, all things being equal. This is the largest meta-analysis to date for total arterial versus non-total arterial, one or more veins. The sample size is very large. The analysis favoured total arterial revascularisation by quite a large margin. Now, multiple arterial grafting, and we've certainly heard quite a bit of that today, means two or more arteries plus or minus veins. Now, if we were to break down multiple arterial grafting into those two components, multiple arterial grafting with veins or multiple arterial grafting without veins, total arterial, there's quite a large survival advantage which is increasing over time. This is the Australian data set. It is non-randomised. It is very large, but we wait with great interest to the Roma randomised study being published. If we look at some of the recent analyses we're working on in this data set and said, well, look, why don't we just have the same number of vein grafts, one, in both groups? So the single arterial was one artery plus one vein. The multiple arterial graft was two or more arteries plus one vein. The survival analysis with about 4,000 in each arm seemed to suggest that there was a small survival benefit in favour of multiple arterial grafting in this intermediate time frame, but then by about 9 to 10 years, these confidence intervals crossed, or at least approximated each other. Logically, that would make some sense if one is saying the mortality is related to the vein failing and you have the same number of veins in both groups, then it makes some degree of logical sense that this would be quite reasonable. If you then turn the discussion onto the extent of coronary disease and use the number of grafts as a surrogate for that, which may be potentially slightly imperfect, and you had an analysis according to, say, 3 grafts, or in this case now 4 grafts, you can see the Cox model table on the left here, and you can see the various combinations that would constitute those 4 grafts. 4 arteries, no veins, 3 arteries, 1 vein, and so forth. What this analysis suggests is that there is an incremental decline in survival as the number of vein grafts increases. And that too makes some degree of logical sense from first principles. If you are at risk of dying because a graft fails, then you must be at somewhat more risk if you have more than one, and so on. The interpretation is that vein graft negatively impacts survival and potentially increasing with the number of veins. To summarise, the late coronary survival favours total arterial. Certainly, in my view, the vein graft is the most important graft in surgery, because this is the only one that has a defined, progressive and ongoing pattern of failure, whereas the arterial grafts, whilst having an early graft failure, do not appear to have a progressive, ongoing failure. I thank you for your attention.
Any questions from, please stay for, we have a while. Any questions from the audience? You have a burning one? We have time.
So, Alistair, the slides with 1, 2, 3 vein grafts, that was using Australian data?
Yes, that's from the ANSCATS data set. Yes.
So Australia is fairly unique in having a strong commitment towards arterial revascularization for decades, really. Do you want to comment on whether you think there's biological plausibility here or selection bias?
Look, in the next talk, in the next session, I'll give you some of the numbers of the Australian data set for multiple and total arterial revascularization, which is certainly, I agree, higher than the international average. But this is a national data set, not a single surgeon, single institution data set, as Jim Tatula sitting there would agree. The practice is primarily those of the individual surgeons not trying to, or not, as the case may be, perform multiple or total arterial. This is just their standard, pragmatic, everyday practice. No, I think the postulate I've proposed is based entirely on the logical, biological, long-term behaviour of one conduit versus another.
So I have at Royal Melbourne, you have many surgeons? Or a group practice, or?
It's we have about 7 active cardiac surgeons and a few other thoracic and similar surgeons.
So when was the last time you saw a vein?
Myself, quite a few years, but in our institution, probably a day or so ago.
Okay, so do most of the surgeons in your practice espouse this attitude, or?
So most of the surgeons will have total arterial or multiple arterial on a very frequent basis, but it's certainly not necessarily the routine practice for all surgeons in our unit by any means.
Okay.
Second question, or follow-up question. Do you think over the last 10 years the practice has changed in Australia in terms of greater use of total arterial revascularization?
I think across the whole of the country, it's been increasing. In Victoria, it's probably been decreasing somewhat from a very high baseline. Unfortunately, the privacy component of our ANSCATS dataset prevents us from being able to drill down to any level. We're trying to work on that, but we can't at the moment analyse either state by state or even hospital by hospital.
Good. Just go ahead, sir.
Eric de Worm, Belgium. What is your strategy on a large right coronary artery with only a moderate stenosis, let us say 60-70%?
Sure. So this is actually the most common question I always get, and I preface it first by saying my analysis is by a national data set. My personal view, I would leave it.
You would leave it.
Well, thank you very much. You can join the panel now. Our third presenter is Dr. Tian, Best Practices in Harvesting Saphenous Vein Grafts for CABG in 2023, No Touch or Conventional. And just before we begin, I'm not sure this is scientific. Show of hand, who still uses veins for CABG here? Okay. Oh, not Dr. Puskas. Okay. Go ahead.
Yes, thank you, Mr. Moderators. Hello, good afternoon. My name is Dr. Tian. I'm from China. Fuwai Hospital is from the other side of the earth. So it's 3 days of ICC, so I will have to stay 6 days in America for the flight travel. I'm going to show the 3-year follow-up result of the China patency trial. Actually, is what is happening on the other side of the Earth. We have nothing to disclose. I personally like this figure very much because it not only shows the overview history of coronary artery bypass grafting surgery, but also it shows that the use of vein graft in CABG has been more than 60 years. So if you look at the data from both the US and the China, you see that the use of the vein graft remains the most common bypass conduit. In the US, multi-arterial CABG is only 14% by the year 2021 from the STS database, and the use of radial artery, although it's on the increase, is only 9%. And in our hospital, in the year 2021, we completed 2,568 cases of isolated CABG, and 90% were performed with Lima plus saphenous vein graft. And if you look at the data from whole China, and the situation is more or less the same. Still, we have the overall use of multi-arterial conduit. Although it's on the increase, it's only about 11%. So the vein graft patency is the weakness of CABG, and everybody talks about the long-term failure. But actually, I think in the past century, especially at the beginning of this century, the mechanism of vein graft failure has been discussed thoroughly. The failure has to be separated, because in the very early phase, we have to do a successful distal anastomosis to make sure, or otherwise, the vein graft will become occlude when the patient will discharge and when happens to within a month. But from 1 month to 1 year, because the vein graft was exposed to arterial circulation, so the passive distension begins. The passive distension causes the structure of the vein graft disrupt, and when that disruption happens, the failure begins. So in the long term, atherosclerosis became the main factor leading to failure. So if we stop the disruption of vein graft, we may stop the failure of saphenous vein. So that is why Dr. Sauder started this technique in 1996, featured by the pedicle harvesting to protect the adventitia and to avoid distension. Dr. Sauder performed a successful longitudinal small sample trials showing that the no-touch vein can successfully reduce vein graft failure. However, a multi-center trial, because of a small sample, did not show a significant difference. So based on the findings of previous studies, the president of my hospital, Professor Shengshu Hu, also a lifetime award achievement in 2018 of ICC, he started the China patency trial to compare these two different techniques. We enrolled 7 different centers from China with a sample size of 2,600 patients between the year 2017 to 2019. The primary endpoint was the short-term graft occlusion at 3 months, and the secondary endpoint was 12 months, and the adverse events. So because everybody knows that the no-touch technique, and the difference between the no-touch technique and the conventional vein harvesting was, you can see it's minimal. If the residents who harvest the veins are careless, it may easily hurt the no-touch vein. So it is touch, it's not no-touch. So we summarized all the residents numerous times to train them. And also because the equipment of the hospital has been upgraded, we can broadcast our operations to one single meeting room anytime. So we called all the senior operators and the junior residents to learn how to harvest no-touch veins several times also. This is the technique of our hospital and also the technique which happened in the Northern Europe. It's different. Well, the no-touch technique we use in our hospital was simple and easy to follow, because we not only want to use this hospital in the teaching hospital, a teaching hospital of China, we also want it to be used in the regional hospital in China. So we didn't use the ultrasound scalpel, and we only used the electrocautery and the seeders for the direct skin incision. And we store the veins not in heparized blood. We stored it in saline plus papaverine. For the rest of the procedure, and it was the same. So the 1-year results show that the vein graft occlusion in the no-touch technique, no-touch group was 2.8% at 3 months and 2.8% at 3 months and 3.7% at 12 months. For the conventional group, it was 4.8% at 3 months and 6.5% at 12 months. This result has been published in 2021. We enrolled 72 surgeons and 52 residents. Our short-term follow-up did not show a significant difference in survival and adverse events. However, we did observe a significantly reduced angina recurrence under 1 year. And for this no-touch technique, we know that it is criticized for the leg wound complication because we have to take more tissue from the leg. And we did observe a notably higher rate of leg wound complication at the early phase of the study, 16%. But we noticed this problem and we trained our residents how to manage the wound and how to suture the leg wound. So this leg wound complication gradually decrease as the study goes. And nowadays in our center, we routinely use no-touch technique and we rarely see such kind of complications. So we continue our follow-up to 3 years, until last year. At 3-year follow-up, 94 patients died, and we have a CT follow-up rate of 90%. Because you may know that a CT follow-up can be very difficult because the longer patient leave the hospital, the less willing they want to come back to the hospital for CT angiography. And we have a team dealing with that issue. We make sure that the patients will receive CT angiography the same day they arrive at our hospital. We have a good relationship with the radiology department. So this is the overall result, graft outcomes of the no-touch group and the conventional group at 3 years. The occluding rate of the no-touch group was 5.7% and it was 9.0% in the conventional group, still showing a significant difference. And the no-touch technique could reduce the vein graft occlusion, the risk about 40%. And also, I want you to show you the rate of lemma occlusion at the two groups. It was 4.2% at 3 years, and also notably lower than RIMA and radio. So this figure very nicely shows the tendency, the change of occluding rate at both groups of vein grafts. Although our vein graft gradually occlude from 3 months after surgery to 3 years, but the no-touch technique keeps the tendency constantly of reducing the occlusion. For subgroup analysis, if anyone can remember the paper we published in Circulation in 2021, there were some incidental positive finding for our subgroup analysis. But this time, the subgroup analysis showed a constant result across all the exploratory subgroups. There were no P4 interaction in all the subgroups. There was no significant difference in all-cause mortality. And there was no significant difference in MACE at the 3-year follow-up. The adverse rate and the overall adverse rate in the conventional group was slightly higher than that in the no-touch group. And we were not surprised to see a reduced rate of myocardial infarction and repeat PCI at the 3-year follow-up. Because when the patient find the vein graft occlusion may cause myocardial infarction, and when patients suffer from angina, they are willing to take repeated coronary angiography and receive stent implanted. So this time we still observe a marginally significant difference in recurrence of angina at 3-year follow-up. So this is the overall clinical outcomes. The no-touch technique significantly reduced myocardial infarction, repeated PCI, and angina recurrence. No difference in all-cause mortality and composite adverse outcomes. So I still want to show you this study taken down by Dr. Mero Gardino. What he found was that by the meta-analysis of tens of thousands of grafts available, only the radial artery and the no-touch vein are associated with significantly lower graft occlusion. So what is the second best conduit in coronary artery bypass grafting is still a debate. So rather than just asking questions, we are determined to answer the question by ourselves. So this is a single center randomized trial we are conducting. We aim to compare the patency and the occluding rate and also the clinical outcome between the no-touch vein and the radial artery. By calculation, our sample size was 774%. Primary outcome is the 12-month graft occluded. In the no-touch group, we use 2 no-touch veins to bypass the target vessel other than the lima, other than the left LAD. And for the radial artery group, we use 1 conventional vein plus the radial artery. Whether to bypass the left or right coronary is up to the surgeon himself. So to conclude my presentation, the lima plus vein graft remains the most common bypass plan in CABG. The no-touch technique significantly reduced vein graft occlusion at 3 years, and significantly reduced the risk of MI, repeated PCI, and recurrence of angina at 3 years. The optimal second conduit for CABG is still unanswered, and the longer-term follow-up, the new RCT is warranted. Thank you very much.
Now let's move on to the Q&A session for this part. If anyone has questions, please feel free to ask.
I'll ask a couple of ones. I was surprised by the lower rate of angina recurrence at 1 year. Could you identify the territories? The same question at 3 years. Could you identify the ischemic areas within the heart?
No, because it was the patient-reported questionnaire, so we could not clearly identify it. Yes.
And how did you define vein graft failure versus occlusion?
We use the Fitzgibbon criteria. The occlusion was by 100% occluding, and plus the string sign on the CT angiography. And the failure was defined by the occluding plus the larger than 80% stenosis. Yeah.
Okay. And at 3 years, your MACE is not significant, but individually, some of the complications are significantly reduced.
Yes, I think that it's because we have a high rate of stroke at both groups. The stroke, if you plus stroke, the composite MACE may become insignificant.
Okay. And lastly, when can we expect the results of the discussion study you showed us?
Yes, the newer study we are performing. Yes, our assumption that the no-touch vein may be less. The occluding of no-touch technique, no-touch vein is lower than that of radial artery.
But the study you presented at single center ongoing in the discussion slide. When do we get the results?
In 2 years.
Thank you.
Yeah, the Swedish group did conduct a radial versus no-touch study using a within-patient randomization, and they report out to 8 years. I think overall patency of the no-touch patients or grafts was higher than radial, although it did depend on the severity of the proximal vessel stenosis. And have you looked at that in your group, or do you have recommendations in terms of severity of proximal stenosis?
Yes, that is a very good question. So we did have a lot of hesitation about the proximal stenosis. So And also we consulted that with Dr. Pascas before we wrote the protocol. So at last, our decision was that the proximal stenosis and the relationship between the proximal stenosis and the radial artery patency was still unanswered. So we set the proximal stenosis was to be at least 75%, whether it was left or right coronary. At least 75%.
Dr. Pascas?
Dr. Tian, a comment and then a quick question. First, thank you for coming all the way from the other side of the world. It's great that you and your representatives from Fuwai are here, the biggest cardiac surgical center on earth. So thank you for making the long trip.
Yeah, you're welcome.
And thank you for presenting this very interesting data. Like most studies, it isn't a very clear answer this way or that way. Has it been compelling enough to change your practice at Fuwai? Is no-touch vein harvest standard at Fuwai now, or is it still something that you are investigating?
It's, I can see that the use of no-touch techniques is the standard in Fuwai now. But also it's up to the surgeon preference, because now we have more than 100 surgeons like me performing cabbage. So some of them have performed 1,000 of them, and some of them have performed hundreds. Yes.
Thank you so much.
Yeah.
Thank you very much, Dr.
We're happy to have Dr. Joe Sabik tackling this subject. Which coronary bypass target should always receive a saphenous vein graft?
Well, thank you. You know, I always tell my residents I never use the word always or never, and I don't think it's a good idea. I'm going to do my best to try to address this, but I suppose I'm going to talk to you about it the way I kind of think about how I choose conduits. These are my disclosures. I suppose the most important disclosure is that I do use vein grafts. I really don't think we should try to fit a specific operation to a patient, right? I mean, we have to select what we do to fit that patient to give them the best outcome. And sometimes that means, you know, using vein grafts, and they're not horrible. I think we just have to understand what their potential is. So as I said, really what I'm going to talk about is how I think about choosing conduit. And I think the most important thing is to think about patency of those grafts, and particularly when you're using that graft to a particular conduit, a particular target, And then how does that affect your long-term outcomes? Now, obviously, we have the most on survival, but there are other things, you know, obviously freedom from angina, freedom from myocardial infarction. And this is probably where arterial grafts have the benefit over saphenous vein grafts. Saphenous vein grafts are more temporary, because we know they develop atherosclerosis. So let's talk a little bit about graft patency. And as I think everyone in this room understands, the most important predictor of the effectiveness of coronary surgery is bypass graft patency. It's whether our grafts stay open or not. And if we think about the reasons that grafts close, vein grafts close with time due to atherosclerosis. Bypass graft patency is dependent on the coronary that's actually bypassed, and that there are certain characteristics of the coronary artery, such as competitive flow, that influence whether an arterial graft, such as an ITA, stays open. There are differences in conduit, and it's particularly with saphenous vein, and there are some patient characteristics that we can't control. Younger patients and female patients have lower graft patency. I think, as you all know, if an ITA graft is open when you leave the operating room, most likely it's going to be open for the next 20 years. Doesn't develop atherosclerosis. However, that's not true about vein grafts, as we saw that beautiful diagram. You know, whether it's trauma that occurs during harvesting or exposure to arterial pressure causes intimal injury, platelet adhesion, mitogenic factors, smooth muscle migration, precursors to vein graft atherosclerosis. So we know that by 10 years, 50% of vein grafts have closed due to atherosclerosis, and the 50% that are open, 50% of those have vein graft atherosclerosis. This was something I became extremely interested in early in my career, you know, particularly thinking about patency. And as I said, it's somewhat dependent on the coronary artery. When we do a bypass graft, if we do it to the LAD, it's most likely to stay open. If we do it to the right, it has the lowest patency, and the other arteries are somewhat intermediate. We all understand competitive flow, that's residual flow in the coronary artery. And one of the things that I was taught 30 years ago when I first became a heart surgeon was that once you got to 70%, there was this big cutoff and arterial grafts were really bad. And so when we were starting to look at this data we had at the clinic, we realized, well, that's kind of not true. It's actually somewhat gradual. But we do know that at lower degrees of stenosis or more competitive flow, our grafts are less likely to stay open. That's not true for saphenous veins, and I know the group in Australia found the same thing. You know, we looked at thousands of vein grafts, and we could not find a relationship between competitive flow and vein graft patency. As I tell my residents, vein grafts are dumb pipes. They just stay open, you know, until they develop atherosclerosis and they close. Arterial grafts are very physiologic. They can constrict if they're not needed. And we see that the effect of competitive flow is fairly stable over time. But one of the things that we're here to talk about is vein grafts. So how do we put all this together? How do we put this effect of which artery we're targeting, which conduit we're using, the effects of competitive flow, and the effects of vein graft atherosclerosis on giving our patients the best outcomes? Again, how do we choose the conduit for the target? And this was some work that we did when I was at the clinic. And what I'm going to show you is a bunch of slides that are fairly similar. Along the horizontal axis is proximal stenosis, which is a surrogate for competitive flow. The less stenosis, the more competitive flow. And along the vertical axis is the percentage of grafts that will stay open. And you can see at ITA and saphenous vein. The saphenous vein is pretty flat, again, because it's not affected by competitive flow, but the ITA graft slightly declines. And you can see at 1 year after surgery, ITA grafts are better than vein grafts. And then when you get out to 10 years, that benefit has increased, and that's due to the development of atherosclerosis in the vein graft and the stability of the arterial graft. And this is why an IMA to LAD helps patients live longer, prevents MIs, and decreases angina. Well, how about if we look at those arteries that have intermediate patency, such as diagonal circ and PDA? Once again, at 1 year, the ITA is better than the saphenous vein, and by 10 years, that gap is widened. Those of you who believe in multiple arterial grafts, this is why 2 arterial grafts is better than 1, you know, in terms of preventing reoperation, recurrent symptoms, as well as likely increasing survival. The problem we get is the right coronary artery, and there was a very astute question asked earlier. What do you do with a large right coronary artery that has a moderate stenosis? Now, when we think about stenosis, again, it's just a surrogate for competitive flow. So a 50% stenosis in a 5 millimeter right coronary artery, it has very different competitive flow than a 50% stenosis in a 2 millimeter LAD. And this is why I think the right, we get into trouble with. But you can see clearly at 1 year, there's probably not much difference in terms of the patency of ITA and saphenous veins. But when you get down to 10 years, when vein grafts have developed atherosclerosis, there may be a benefit of ITA grafts or arterial grafts over the long run. But again, it's not as well defined as in the LAD and other coronaries that we were talking about. So trying to answer that question is, when is saphenous vein grafts always we want to use them? It's really hard if you look at it just from a patency point of view. But there may be an argument that in patients with moderate stenosis, there may be a better thing to use a vein. The question is, does it make a difference? I think there are some people in this room who says, probably doesn't make a difference. We probably can leave all these moderate stenoses alone. And so I think that's when we can start to think about survival. We know that an IMA to LAD improves survival. Vein grafts improve survival. You know, one of the things that I've always found very interesting is if you look at the Berry study, all the survival advantage in the surgical group was on the patients who got an IMA to LAD. There were a lot of patients in that group that had 3 vein grafts versus 3 PCIs. There was no difference. So vein graft didn't improve survival as compared to balloon angioplasty, which I always found quite amazing. But anyway, as you know, there was a lot of work done, particularly on the interventional side, and you're all familiar with FAME, which looked at should we be stenting or intervening on moderate lesions? And the answer to that is no, because of the upfront risk. We then asked ourselves the question, if The only reason you're going to use a vein graft is in a situation of moderate stenosis. Does it help that patient, or does it hurt the patient? I think the first answer we found that grafting a moderate stenosed artery, didn't hurt anyone, and that was very important. You can see that on the left-hand side. But one of the things that we learned, which kind of surprised us a little bit at first, was that if you put a saphenous vein graft or you left that moderate stenosis alone, it didn't change survival. However, if you put an arterial graft to that moderately stenosed artery, you could improve that patient's survival. Now, Mario might be here. It's an observational study. I agree. There's some bias in it. But that we found very interesting. So saphenous vein grafts to moderate stenosis don't affect survival. But if you put an arterial graft, such as an ITA, to a moderately stenosed artery, patients live longer. And we asked ourselves why that might be. And I think you need to take a step back and think about the natural history of coronary artery disease and how it progresses over time to understand that. And so we looked at that. And as we all know, coronary artery disease is a progressive disease. And if you look at arteries that are grafted versus those that are not grafted, the progression is less in non-grafted arteries, but the progression is greatest in saphenous veins and less than in ITA grafted arteries. And we also know that the patency of ITAs is less in moderately stenosed arteries. But in saphenous veins, it's really, again, due to this atherosclerosis, and so it's less. So you can actually then calculate how many patients that you put an arterial graft to that are moderately stenosed, the graft will be open when that stenosis reaches significance, greater than 70%. And then you can say, well, then in this situation, the arterial graft is protective. And this is why we believe that arterial grafts help patients live longer who have moderately stenosed coronary arteries. And saphenous veins do not, because the patency rate is relatively low. So it's a really hard question to answer. So I think the answer is always, is probably, it's never always. But we're always not just thinking about survival. It may be symptomatic relief. It may be a very old patient who doesn't have radials and has bad diabetes. So there are situations where you do use vein grafts. But I think when we think about it from a point of view of patency and survival, you can't make a great argument for vein grafts. But it has other benefits that I think we need to think about. But that one group might be that right coronary artery that's only moderately stenosed. Thank you very much. I appreciate the opportunity.
Questions from the floor? I have a few questions for you. Probably a silly one, but when you're talking percentage of stenosis, you're talking diameter or surface?
So you're right. I mean, this is obviously not physiologic. This is angiographic estimates that we normally use.
Okay.
It was the data that I had available when we did these studies. So there's some weakness there.
So if you go in, the left side system is severely diseased. You have a 40% lesion in diameter. On the right, what would you do with that?
40% in the right, I would leave it alone.
Leave it alone. Good. If the patient has seen a cardiologist in the days before he needs operation, and he's got an open stent on an artery.
How old is it?
5 days.
I actually put a vein graft to that. I know there's a lot of thought that what you should do and what you shouldn't do, but I'm always worried about what's going to happen perioperatively. I have seen where people have left early stents alone that have thrombosed very early postoperative, and I'm very worried about that. So I tend to put a vein graft on. I don't think it's harmful. Whether it's necessary or not, I don't know.
Okay. Other questions from the panel?
I have a question. So someone has isolated left main disease and not very severe. Would you use 2 ITAs routinely, or depends, or?
So you're talking about maybe a situation where somebody has, let's say, a mid-body 50, 60% left main stenosis that doesn't affect the bifurcation. The operation that I love to do in that situation is I tell everybody I make my own left main. I take the eye of the left, put it to the LAD, take a segment of the right, and go to the circ. I think you avoid competitive flow problems in that situation.
Okay. Thank you.
Thank you.
Thank you very much, Dr. Civic. Now let's move on to the last speaker, who is Dr. Giovanni Soletti from Weill Cornell Medicine. And today we will talk about current evidence on external saphenous vein graft stents for CABG and the meta-analysis.
Thank you. We're running a little late, so I'll try to be as quick as possible. Thank you for the organizers and to my mentors for being here today and discuss this topic. I have no conflicts to disclose. This is a figure from the latest SCS report showing that the use of a multi-arterial grafting and isolated CABG is still limited, like around 14% in the United States. And so this means that saphenous vein grafts are still the most used conduits for CABG. And unfortunately, this doesn't come with a big toll to pay, which is a higher rate of failure, which is like from 3 to 12% occluding before hospital discharge, up to 25% failing at 1 year, and only 50 to 60% remaining patent after a decade. And so this is mainly due to what we call intimal hyperplasia, which is an adaptive response to higher arterial pressures. And the concept of externally stenting SVGs is not new, and it's been around for quite like a long time now, as you can see from the years of publications at the bottom of the images of these two preclinical studies that were published back in 1963 and 1998. But unfortunately, this concept has like not been assimilated into our clinical practice until recently, when the VEST device became available. And as you can see from the image, this is a tubular braided with a braided structure device composed of deformable wires that can be adjusted to the length and width of a vein graft, and it's specifically designed to prevent SVG from stretching under higher arterial pressure. And this is like a screenshot that I took from a beautiful video published by Dr. Sigrid Sender, who should be here with us now. And it shows like an IMA on the left and two VEST-supported SVGs on the right. The VEST device was, of course, tested in a preclinical model, and what the authors found was that the mean intimal hyperplasia area was significantly lower in supported SVGs compared to controls. And this was a study that paved the way to the conduction of human randomized controlled trials. So we performed a meta-analysis of these RCTs comparing VEST stented to controls SVGs. And our primary outcome was graft occlusion. Our secondary outcomes were repeat revascularization, intimal hyperplasia area, intimal medial thickness, and lumen irregularities. This is a figure showing our search strategy process. We included 2 studies, while 3 studies were excluded. VEST, and these are the reasons. VEST-1 and its long-term follow-up, VEST-4, were excluded because 30% of the sample size underwent a variation of the device implantation technique. And VEST-2 is a prospective study, so no randomization was performed. So VEST-3 and US VEST are the studies that we included in the meta-analysis. The mean follow-up was 1.5 years. More than 400 patients were included. 679 SVG were analyzed, of which 341 were stented and 338 were non-stented. These are some of the main patient and vein characteristics. As you can see, the proportion of women is always, like, as usual, less than 20%. Hypertension, hyperlipidemia, and diabetes were the most frequent comorbidities. The majority of patients presented with no signs of vein varicosity, and the preferred SVG harvesting method was endoscopic technique. Okay, so now let's take a look at some forest plots. This is for the primary outcome that, as you can see, is graft occlusion. We found no difference like between VEST, SVGs, and controls. And this was confirmed by a secondary analysis including VEST4. As to our secondary outcomes, this is the forest plot for repeat revascularization. Again, we found no difference between VEST, SVGs, and controls, while a significant reduction in VEST-supported SVG was found in terms of intimal hyperplasia area and intimal medial thickness. Lastly, we found no difference in lumen irregularities expressed as fit-skip and patency classes. So, based on the findings of this study, we can conclude that VEST device reduces what we call the atherosclerosis predicting factors, intimal hyperplasia area and thickness of SVG after CABG, but this reduction does not currently translate into fewer graft occlusion events or a lesser need for repeat revascularization compared to controls at 1.5 years after CABG. So we need more long-term data, larger studies, because we see a trend towards better outcomes in VEST-supported SVG. And meanwhile, either SVG harvested with a no-touch technique or the adoption of arterial conduits, as said before, needs to be used to improve long-term patency. These are the paper that were recently published on this topic. If you want, you can scan the QR code and they'll take you to the page. Thank you.
Any questions from the floor? If nobody comes up, what's the level of enthusiasm for the backers of VEST and the surgeons involved in the prior studies to do a larger long-term follow-up studies? How's the morale?
Well, I think that as I said before, the take-home message, the more important is that we see a trend towards better outcomes in the VEST-stented SVGs, okay? But we do not see less graft occlusion events or repeat revascularization, okay? So we might see in the future this happening, but the problem is that we need to tackle early graft failure, which remains a problem because the follow-up of these studies is a year and a half. So, and we usually see these early graft failure events in less time.
So I'll rephrase the question. What is your level of enthusiasm for realistically seeing other long studies with more patients on using the VEST, considering everything that's been said in this session about veins?
I think that everything is welcome because from the 1962 where the first SVG was used by Sabiston for CABG was used to now, we haven't seen many advances in SVG failure. So we need more data about this, definitely.
You will make a very good politician.
I think there is a European long-term registry. Is that correct, David?
Yes. Correct.
Just kidding.
There is a long-term European registry which has been conducted by the company. One comment I would make, however, when we did VEST1, we brought back a small number, 19 of the patients at 5 years, and we saw absolutely no progression of vein graft disease over that 5-year period. The numbers are small, but it's encouraging. And the way I look at this is we have been preaching about arterial grafts for 2 decades and made very little impact. And to me, if you can use these devices very safely, so we didn't see any detrimental episodes with them, but if they really do prevent the progression of vein graft disease out to 10 years, then it's a major advance. And we've repeatedly said that you get this kind of early failure rate of vein grafts. If you look in the literature, it's somewhere around 20%. So you're not going to affect that early with these stents. That's not what they're designed to do. They are designed to prevent intimal hyperplasia and minimize atherosclerosis. And as I say, although the results are preliminary, in the 19 patients we brought back at 5 years, there was absolutely no progression of vein graft disease, which you might have expected to see over a 5-year period. So I'm still cautiously optimistic. I think the take-home message is we can talk all day about using arterial grafts, but 80% of all grafts put in the heart are vein grafts. And if you can use a device that takes a minute to apply that genuinely reduces intimal hyperplasia over the long term, I think it's probably going to be a valuable thing. Thank you.
Thank you very much. So we obviously skipped the panel discussion. We'll leave it to the next session. Thank you for attending. Thank you very much.